notifications on. Or am I wrong? It might be more.
No, I mean, so the opportunity here is astounding. Let me just give you two examples. One is right now we're sending an alert that says your patient just arrived at the hospital. Right? I mean, and this is a minute after it happens, we can send that alert or a daily summary. We can start to push the full clinical document. We have a technical capability now. If a hospital sends us a CCD document, we can push that straight to the PCP. If you start thinking about these risk scoring methodologies and the ability to apply a real-time risk score and shoot that to someone, either to the arriving hospital, right, so to the registrar or to the care coordinator at the hospital as they arrive, you can insert a risk score, or to the PCP. I mean, all of these things are not that far off. I mean, that is the infrastructure, the railroad to do that exists. So there's a lot of very, very cool opportunity from a care coordination perspective beyond the kind of Medicare data file that I think we should be thinking about.
So just in terms of that.
Ben, microphone, please.
Attributes, sort of the point that Frank made and the point that Scott's making. You know, I think that explicitly having exchangeability, it may be up there, but the ability to exchange information across systems is going to be very important. And I think you're sort of catching it, but maybe not exactly. The other point I would say is where there's further granularity needed is flexibility. I mean, predictive modeling, God knows, I don't want the predictive model to be in the hands of the registrar who's saying, ooh, this person looks a little risky. I mean, I think the idea
down the street.
I think the idea of really data where it's needed, so putting predictive modeling is different than who needs care management tools and who needs quality improvement tools. So data at the right place at the right, you know, that old cliche needs to be distinguished here. Flexibility to deliver the right data at the right time is really important. And you know, the underlying data elements are a little different in predictive modeling from care management to quality improvement, and it's a vast data infrastructure you're talking about, because one set of data from any entity today is not going to be sufficient to meet even those three broad contexts. But I think right data, you know, and you know, we talked about timely data, but we also need to talk about long data. The terminology of big data is largely thought about, a lot of it, but it's also long. And our trend, if we're going to, we need longer time series than we've had before to look at how we're doing.
Oh, you meant the reports that we have, long data.
Oh, I'm not doing that.
I guess, I think it's in another one. You know, we talked about claims. We talked about the importance of linking it with HIE. I would add that the HMH has a lot of data, maybe something about the place that they're, you know, some other data kind of creating, not in terms of the time dimension, but also the dimension of the data itself to have more clinical and social dimensions trying to merge up. So I think wide data, would that be the nice thing?
Deep and wide.
Deep and wide.
How quickly, how frequently are we going to get the Medicare data?
On a monthly basis with 3-month lag. And we are,
Well, that's the point. I think that's the point, that can't be used. Why? That's not going to be. That may not be the most essential, but it could help.
When you think about that Medicare data, keep this in mind too. So the Medicare fee-for-service practitioner has a year to submit that claim. You know, and you know, if I'm a practitioner, I want that claim in the day I do the work.
Yeah.
Cash flow. Well, that's why I asked, because I've worked with Medicare data before, and by the time you get it, it's so old that.
Right.
I mean, old in terms of doing anything real time.
Mm-hmm. Mm-hmm. So I think the ask is to have 3 years of data so that we could use the 3 years of history of the beneficiaries. And I think the value of predictive modeling is rather than waiting things to happen, try to predict and then prevent. So I agree with you. For real-time management, the uses of data would differ based on what data you have.
I like the idea of creating these principles for a larger data infrastructure to include some of the data you were just talking about, the public health kind of data. I would add that I think we've talked about this, but it's not in our principles yet around the access. I know there's a whole policy board that talks about data access related to HIE. And I don't know whether this would, all the decisions about who can access this data would be made at that level, or is it a separate entity? I would want them to be, maybe they're not exactly the same, but at least coordinated. So I would think that needs to be in our principles. And
but the practitioners have access to the data for their patients. Right. So it wouldn't be a problem for your members or my doctors.
Yeah, it does get a little more complicated, though. So just one easy example is, let's say that I'm a hospital and I have a person who has a visit at my hospital, and then they get readmitted to Trish's hospital. I can see everything about them at my hospital. I might want to see what happened at her hospital. Did I do something that is having a sequelae at her hospital, or do they have different protocols? There's kind of different variations of how much exactly you can see. I think that's those kinds of questions are thorny. And there's other examples too as we start to look at taking on like maybe a phase 2 of a global budget, what that looks like.
Well, I think the HIE policy board is pretty well dealt. I think the HIE policy board has dealt pretty clearly, with some depth about what the use of the data for the HSCRC's purposes. I think you're raising now a question that we haven't really dealt with yet, and that is as we're trying to deal with issues like global budgets in hospitals and pushing the care out in the community, how do we now share that data? And we haven't dealt with it, so perhaps it would be a good thing to, for David Sharp to become part of this conversation.
Rather than, I think we've talked about that internally, and I think we think that the HIE policy group is a better group to discuss this, primarily because it has considered a large number of consumer representatives, and trying to reconvene this group to include representatives from the community is going to be really hard. I think that they've wrestled with these issues for a long time. They're, at least I'm not sure I quite agree that we've solved all the HSCRC data sharing issues, but it has been sort of opened up. So I think that would maybe having some HSCRC folks actively involved in that would be a better approach than breaking off a separate data sharing group from this group.
As the policy group started to look at other people who would want to be involved in the care of the individual, so I would assume beyond the provider, other workers.
What do you explain? Who do you talk about?
Care managers, people, that nurses, not necessarily just the physician.
Well, we just need to make sure that, we're protecting the patient's rights. I mean, that's would be my big concern is, when we start opening it up beyond people, I even got a little nervous when you were giving your example, because I could see one hospital poaching or dumping a patient or doing that. Not that would ever happen here, but, I could see those types of scenarios. Maybe one Baltimore area hospital might start going, maybe you'd be better at Hopkins. That would be or whatever. I could see stuff like that happening, and maybe it does now, but I just, so we have to be careful.
Yeah, no, I agree. I'm assuming that within a hospital that more people than just providers or physicians are getting access to that data to help manage it. And so in order to make this work, I think you would have to go into that, start discussing those issues, but making sure that the
I think it starts to get into the issue of contracts and active care management versus treatment relationships. Right. And when you thinking about hospital survey data, if there's a contractor that's doing a survey on behalf of the hospital for patient experience, afterwards they've got a contract with the hospital to do outreach, and they have patient-specific information to do that. That hospital's engaged in a contract with that vendor. If you think about maybe a scenario Tracy was giving, but bigger, if you're talking about super utilization, cross-hospital, and there's someone that's had 5 visits here, 4 visits there, 6 visits at this other hospital, and they live within the primary service area of a 4th hospital, which they just don't go to that hospital for care, but yet that hospital cares about them because they're in their PSA. Who should be reaching out and engaging that person? And do those 4 or 5 hospitals or 46 hospitals have relationships with one another over time, or with care managers in the community? I think those are the answers. We certainly don't know.
And I think when you look at health departments that have used CRISP, Worcester being the example, and how they've used it and working with their hospitals, I mean, to your point, there are going to be more community folks involved in the care management and care coordination, so I don't think it is restricted just to the hospital and primary care providers.
So did I guess in terms of our charge, like we are still at the high level, so if you are envisioning Chris holding this idea and doing some analysis linking it to HIE, then the questions about data sharing, governance, we could recommend in our report to say the HIE policy board should be looking at this from this perspective, and if you think there should be additional members to be added now that we are broad, I don't know, it may be a different time.
5 now, a couple more.
So I think, to Ben's point, I don't think we have the expertise, or we didn't get together to come up with the detailed policy. We are trying to be still at the high level and provide direction to the HSCRC Commission to kind of say, okay, as HSCRC, what are the things you need to promote and what are the things you need to get involved in? So I think if you keep it at that level, everyone will feel comfortable.
I would only suggest that you put in your recommendation that there be some direction around the specific charge and some time parameters, if you've got time parameters that you have to meet.
So the only comment I'll make, and I think I agree with the high-level principles and all of that, but I don't want to miss the boat in terms of making some of these decisions if the hospitals feel the urgency now and begin to build it themselves, that we've missed sort of a window of opportunity to help structure this. So I've been in a number of different meetings where I hear that hospitals are feeling like they're already so far behind that they're jumping right into it and starting to kind of build it. So, if we wait 6 to 8 months, have we lost the...
Yeah, we are past our first performance year.
Yeah, so, I mean, I just worry. I
you're right.
think I don't want to spend too much time on the high level without...
I think that's a good point, and I think we could sort of tie all of this together, because if all of this work stays in big work groups, it will take a long time to do. And I think we all want to move this along a little more quickly. And while I think the HIA Policy Board is a good group because it's got good representation, it does take a long time to move through that process. And that group already has several things on their ticket to address. I don't know whether, could there be a smaller group that works on this with a facilitator and then take some recommendations? I get concerned about putting in this report that this piece will go here, that piece will go there, because I'm concerned that it will get to be too long.
So I think that the idea that Sally Ann had of a timeline, a time window for them to do something or not, would be a way to approach this. they report back. Because I think that you're right that there is an emphasis on giving, particularly the consumer representatives, a lot of time to work through this. All that being said, they did have to wrestle with the resistance from the first set of regulations, which were the product of the first work product of that group. What generated a lot of concern was concern voiced by the health systems, not the consumers. So that's something, it's not just the consumers that are going to raise issues, but I think the idea of giving them a certain amount of time to work through this would be a way to go, rather than breaking off and convening another group of consumers. Consumers are hard to get engaged to begin with, and this group seems to have pretty capable and knowledgeable group.
Well, and what Dr. Sharp does is when he's got a charge like that, he'll pull a smaller group together and come up with something for people to react to. Let the whole group, rather than try and read it, work it out through the whole big group.
Right. I guess my question, since I'm not very familiar with the policy and the decisions there, you already made certain decisions vis-a-vis the Chris. I guess the first question to me is, with the new additional data in the care map club, what are the additional things we need? What is the gap that we are trying to identify in terms of governance and all that we want them to figure the details out? I'm not sure.
I think that's why I'm saying that have a smaller group of, probably, I could probably point to a few people around the table here, have that group get together with a facilitator to lay out, here's what we really want to do with this. Here's where we want to go. Get really concrete about it. And then included in that list would be, here are the issues that are now raised that the policy board needs to deal with. And then those can go to the policy board. But I think, as we've talked about today, the governance, the transparency, how this functions, what we're going to do with it exactly, it's a little bit nebulous still. I mean, it's a good idea, and we're headed in the right direction, but it's not, I don't think it's clear enough right now for a policy board to start taking action on it.
Oh, I think that's absolutely right, that there would be some specific questions, primarily in the context of what you've sort of raised in the what are the arrangements on data sharing when the relationship between a provider and a patient or a potential patient becomes indirect. And I think that's the specific. There would be a question or a set of questions to this group that you wouldn't throw this open in this way to them. Otherwise, you're going to take a long time.
I agree.
So do you think if we were to get a subgroup from our members, do you think we can come up with that specific charge? Or do we need to?
I'd say one informal group directing a somewhat quasi-legal group would be, I think, just a question to them with a request. Or if it's formally from HSCRC, it's a little different, but one work group charging another.
Not the charge, but if you were to bring a couple of people who kind of know that part of the world and the care management part of the world get together, and the report, if we identify, we identified how are you going to share the data if the provider is indirectly, that's one. Maybe find other things that we can already include in the June report, maybe July. We have another report, by the way, in July. So I think we have time, but at least something for them to start with.
Yeah, well, I think we are aware of this question, and we've brought together a group of attorney generals, assistant attorney generals, to talk about some of the issues from the standpoint of the state. So, it could also be just a communication from HSCRC to MHCC to get the.
Actually, I would like I would like to hear about the conversation you're having with that group, and if we can add some of those conversations to the group so that the HSCRC community as a whole is informed with the discussions you're having.
Your attorneys are involved.
All right. So, but they don't specifically report, so they are not part of this work group, obviously. I would like, I mean, it will be helpful to have a section there about your work and summarize some of the discussions you're having, so we don't rediscover the wheel again. You know, have some substance to our report where we collect that information already. That's what my point. All right, so
can I ask one question? Okay, so we've talked about monitoring. We have that straight. That data is going to be done by the HSCRC, and that sounds like it's cool, and we're in good shape. We've just talked about the second part, which is the care management, and it sounds like we're leaning towards Chris. We got some principles, so that's cool. How are we dealing with, because we haven't talked about, the gain sharing data? Whenever, at some point in time, that other work group that's out there floating around is going to pop up with some magic report so we can do gain sharing, and then someone's going to have to do data around that. Who's going to do that, and how are we doing that, and how are we dealing with that?
Jean, you are on fire today. Great. So on the June 18th, on the June 18th, we kind of outlined, like, we are going to hear back from the performance work group, and the physician is not there. Once we have more concrete view of what the gain sharing is going to look like, I think, and we can meet more, you know, after June 18th to discuss that. But without really knowing where they are going, for us, I think it will be hard to think about it.
Let me say this, though. I do suspect that some of the same discussion, maybe at an even more intense level that we had on the care management issue, will occur with regards to that issue. So it seems to me that anything we can do informally among ourselves in between now and that meeting to try to bring us closer together, because we want to not have that sit around and have nothing happen with it, you know. So that would be my only point, and the only reason I bring it up.
Yeah, we may, you know, we've been doing these ad hoc subgroups, you know, the total cost came here, but it may make sense to have a combined, you know, a subgroup with representatives from everybody.
I mean, is that going to be the HSCRC is going to control that data and control that process? Is it going to be Chris? Is it going to be some other entity? Is it going to be a new entity? Is it going to be some trade association?
I mean, first of all, I don't know what data is really going to be in there.
Have to keep track of all the data.
Scorekeeping data. So you're raising excellent points, and maybe this is a place where a subgroup across some of the different work groups would make some sense. In terms of the physician work group, they're at a critical place next week, and in the coming weeks, they've got they're going to be talking about sort of the direction they're moving next week, and we'll see. At this point, I'm not even sure what options that they're settling on. So we still have to get that landscape a lot clearer before we know what data we'd even be talking about. So I think more work needs to happen in that group, but you're raising an excellent point to bring it back together.
And speaking of kind of working with other work groups, the performance work group is going to be meeting on May 9th, and we invited the faculty from Johns Hopkins University to think about the population-based measurement and the data and infrastructure. Unfortunately, his schedule didn't allow us to create a combined joint meeting with them, so I would encourage all of you to come and be at the table, because it's really hard sometimes to differentiate the measurement piece from the data piece, and I think his presentation is absolutely right in the middle, and both groups will have a lot to contribute to the discussion. We'll send information via email for the webinar and the meeting specifics. I don't. 1 o'clock. All right. Any final departing comments? Thank you very much for very good discussion. We'll try to summarize and expand the list, and we'll have some document for you to react to for the next meeting.
Do we need to comment on the total cost?
Oh, yes. The total cost of the report that we reviewed, the draft report, if you have any other comments, please send it back to us by Monday morning. Monday noon. So we can incorporate them.
That's really right.
No, but we need to put it in the Wednesday, and we got some of them already during this meeting. Yes, if you have anything else, Monday noon, and we'll put them in for the Wednesday package.
Can I take a chance to ask about another work group draft report, the performance measures?
Sure.
Performance measurement. I thought they had an April due date for a report also.
Efficiency?
On the efficiency?
Yes. They're working on it.
Okay.
We define April broadly.
April is, it's the May Commission meeting, but April. Yeah.
So,
Yeah.
Okay.
6
All right.
hours.
Just a second.
It's not. It's going to go probably Friday.
Is it nice?
I still think I'm in February. Chris told me that she